Hi everyone. We'll get started in a couple minutes, just giving some time for people to join and finish other calls or grab their lunch, depending on, or maybe coffee, depending on where everybody is. So I guess it would be coffee for folks in the Western Hemisphere. So with Carolyn, hi. Maybe even happy hour for some folks in Asia that might be joining. So and feel free to add in the chat where you're joining from. Let's wait just one more minute. All right, great. Let's go ahead and jump in. So welcome everyone. My name is Chase Perfect, and I'll be moderating the webinar today on the Values and Preferences Survey on COVID self-testing, led by Find. And before passing it to Sanyal to present the study, just wanted to present some background on kind of the context of this meeting and some updates from the civil society side. So myself and Carolyn Gomez are both representatives to the diagnostics pillar for civil society. There are about a dozen representatives of civil society on the diagnostics pillar participating in different working groups. We will add our emails in the chat, joined by a couple other representatives. FIFA, for example, is also a representative and the point person on the facilitation council. So we have a few representatives on the call. Feel free to share perspectives and questions with us going forward. And I'm also, along with Carolyn, coordinating the civil society work on the diagnostics pillar. And in this role, the coordination involves support for the representatives in their work on the pillar, but also engagement with larger civil society. And that coordination work has recently come on board, so we hope to have more of these kinds of events in the future. So that's an update on the platform and on the civil society representation. An update on ACT Day to share is the recent release of the new strategy. We'll put the link to that in the chat. We'll put the link to the new ACT Day strategy in the chat. So there's lots of relevant information there. And as a civil society delegation, we're following that very closely and definitely going to be sharing more with you and developing input on how to provide our perspective on it. So before passing to Sanyal, just a few housekeeping matters. the meeting is going to be recorded, and Courtney will be trying to DJ or MC the mute button, but it is a meeting format, so we hope to have opportunities for people to make interventions with their questions. Of course, as Sanyal is presenting, if you have questions, don't hesitate to put them in the chat, and we'll try to pose those questions in real time if they're relevant to a particular slide. Otherwise, if they're relevant for the question and answer, we can get to that. I'm adding right now the the unedited kind of framework of the proposed agenda for the meeting today. And I think with that, just before passing to Sanyal, I don't know if many of you are familiar with values and preferences surveys, and I asked Sanyal to present a bit of the background on also the approach of values and preferences, because it's a really interesting tool. And so in addition to this particular study and the findings that are relevant for COVID, we also hope that something you take out of this is the approach of values and preferences and the relevance of getting feedback from both users of technology and service providers, and the importance of collecting that information and using it to complement other info that's collected and triangulating it with other perspectives that are being shared by policyholders and the like. So with that, I'll pass to Sanyal.
Great, thank you very much, Chase. And I'd like to thank you and Caroline and Courtney for working with us, and Karishma for facilitating this to happen. We're keen to discuss and share our results, and also get a better understanding from you guys what further information is interesting. Are there particular things you want to see come out of this? And what do you think could be helpful to get the messages? What are the messages that, you know, civil society and community feels is important to get to decision makers and implementers? And how can these types of work assist that now and in the future? So I will, it looks like it's good. So you're sharing, you can see my screen. So yes, as Chase was saying, why embark on these values and preferences, and what is values and preference? What are other ways to gather foundational knowledge about a new intervention or technology, and why is that important? And why is it important to engage community as an integral part of whatever this research is from the beginning? So we want to, you know, you have an idea for a great technology, and some technocrat somewhere sitting and they're like, this is a really great technology, we should do it. And so they start thinking about if it's technically feasible, if it's possible, and whatever. And those are important things to understand. You want to have a technology that works. You want to have a technology that's at a certain price point. But other really important things to understand are, what do the end users think about this technology? Particularly in the case of self-testing for COVID, SARS, or HIV, hepatitis, STIs, the end user is also the recipient of care. So understanding what they think, and they think that they may like about the technology, concerns they may have, ways they may think they would like the service provided, other supportive things that they think they would need to be able to act on the results. So to gather these, we do values and preferences. But there are also a lot of other ways to gather important foundational knowledge. One of them being a market assessment, right? So this is something that's done to try and understand what potential market size are. This is really important because you want to convince manufacturers and the like that it makes sense to develop this technology. It makes sense to put the price point at an affordable point if you have these volumes of scale. You also need to understand high-level decision makers, high-level policy makers. Would this new technology fit within the regulatory landscape of their country? So that's a really important information that comes generally from market assessments. And then you have feasibility and acceptability. Now, this is usually after the end user has interacted or manipulated with the technology. So in the case of self-testing studies, you enroll people at a clinic or a hospital or a harm reduction site, and you have them go through the test of the self-test, the steps of the self-test. You see how they did. And then afterwards, you ask them some questions on a survey. What did you think about it? What did you like? What didn't you? And maybe you do some in-depth interviews to further understand what the participant felt. And this is really important. It shows you how participants can manipulate the device. Can they do it correctly? Can they read it correctly? Are there challenges with any of the steps that maybe could be addressed? But it gives you information about a specific group of people. Namely, these are people who already interact with the health system because they're already at a hospital or primary health care. They're already interested in at least pursuing this device. They signed up for the study. So it's important information, but it is of a specific group. And then you have values and preferences. And this is pretty broadly defined, but the intention here is to understand as cross-sectionally as possible the thoughts and feelings about the end user that you're trying to establish, what they think about a diagnostic technology, if they would use it, if they have concerns, how they think it would fit in the health system, etc. So we'll be talking today about the values and preferences. So specifically for COVID-19 or the SARS-CoV-2 self-test, why are we doing this? Well, we know that FIND, in the context of ACT-A, with many partners, is pursuing a COVID self-testing, understanding how that works, how that fits in the current pandemic. And part of this work is looking at that market assessment. It is issuing an RFP for manufacturers to develop high quality, affordable tests that could be scaled up over low and middle income countries. There are several partners who are doing different evidence generating studies to help inform normative guidance. So it's a giant packet of work. And one of these pieces in it is the values and preferences. And what we want to understand is from the end user's perspectives, the acceptability, feasibility, potential values and risks, and advantages and disadvantages, and service delivery preferences about SARS-CoV-2 self-testing. Now, this work came about because there was people thinking like, well, would self-testing make sense in these circumstances? Maybe people wouldn't report their results. Maybe people wouldn't want to take it. So instead of these kind of maybes, what's going on? This is an attempt to systematically and structurally answer some of those questions from a variety of countries. So we are working in Peru and Brazil, and Nigeria, Kenya, and South Africa. We've added Malawi with a qualitative component only, and I'll explain that a little bit further. India, Indonesia, and the Philippines. And we're working with several different partner organizations in each country to conduct the study. You'll see here these partner organizations range from community and civil society groups to established academic institutions to market research groups. And so this was really chosen by the ability and reach to do the work, as well as the time. We wanted to get this done fairly quickly because we feel that this information was really important to get to these other stakeholders and implementers so that can inform their work, and hopefully they can design strategies and interventions that well meet the needs of people. So it's a mixed method study design. So we have a standardized global protocol, which is adapted in each of these 8 countries. This was important because we want to be able to look at the country level results, but also we want to be able to aggregate these results up. And so the way that you can do that with certainty is if you know that the data collection process, methods, and tools are the same across all the countries. It consists of individual interviews, group interviews, and then a survey among general population and healthcare workers. And it's looking at 4 different themes: current testing for COVID-19, as well as current perception of risk of COVID-19, value of COVID-19 self-testing, actionability post-COVID-19 self-testing. Would people report the results? Would they isolate? And preferences for COVID-19 service delivery models. Here on the bottom is a link to the methods manuscript. So this has been accepted for publication. So if you actually want to read the detailed like the methods of the protocol, as well as see all the data collection tools, you can do that through that link. It's like 80 pages though, so I suggest you look into it only if you're very interested. So now, who are we targeting? Who are the end users that we want to understand this information from? Well, we want to attend healthcare workers, from community healthcare workers up to specialist physicians, pharmacists, lab techs. So the variety of people that self-testing, it's important to get their perceptions on COVID-19 self-testing. Then in the general population, and this is tailored to each context. And then implementers and decision makers. So I will pause here and see if I see there's one question in the chat, or Chase, if you have anything, or if anyone would just like to ask anything about the methodology before I go on. Oh, sorry, I haven't finished the methodology, but I'll pause here anyways. Chase, you want to say anything?
Just jump in with Brooke's comment about, if I understand correctly, that as it's a prospective study, some of it also doesn't reflect how the rollout will evolve elements that are being measured. And I might add to that as well, the sort of catch-22 that we can often find with the request for evidence showing that the intervention is going to be effective for it to get approved to be able to be implemented. That you find that with the self-testing for hepatitis C, for example, that they want evidence that there's values and preferences for it so they can approve it and roll it out. But, and kind of as Brooke is highlighting, there might be some elements of, especially on the positive side, of finding that it's easier to use or how to improve use, et cetera, that are hard to measure before it's actually been rolled out.
Absolutely. I mean, and that's a critical point. This is theoretical, right? This is theoretical acceptability. So it's intended to be foundational. And then the idea is that once things are being made available and people have more experience using the test, then you go and you do further work to understand. You can do discrete choice experiments. You could do a lot of really important things after the work or after the intervention has been in an area. Yes, Brooke?
Well, I guess a related point is the study going to do anything about raising the possibilities of test and treat? Because, you know, as I'm sure Chase and others have talked to you about in the past, you know, it's our hope that the availability of a beneficial treatment will be a huge motivator for people to want to undergo testing, because there's something in it for them. So I know you haven't gotten into all your questions and everything yet, but I do wonder whether there's at least an approach that tries to find out about acceptability that's related to the promise of treatment.
I think that's an excellent point. One of the areas that we do look into in the survey minimally, but more in the qualitative, is understanding the perceptions of risks and some of the drivers of testing. Now, that question that you're asking, I think, is much larger than just self-testing, right? So this driver it's about the motivations of testing as a whole. What is in it for people if they don't feel there's an actionable way forward? And we did see, and I'll talk a little bit about this, I can expand in the Nigerian results, that yes, well, there was a lot of people who were like, COVID is not very high on our list of concerns. We've got a lot of other things that are much more pressing to us. And secondarily to that, there was a feeling that there wasn't, what's the value in getting a diagnosis, because the actionability that is not quite clear. So I absolutely agree with you. And I think that this work will be one piece of many that builds into our better understanding, because I don't think that we have such a good picture right now of what the motivators for people are on those different levels, but they're very important for sure. So to dive a little bit into the quantitative survey methods. So just to say that we assumed that at least 50% of the people would accept self-testing. So that is the assumption that we made to generate our sample size. And so through that assumption, basically we need 196 people in each of the urban and rural areas in each country to have a relatively high confidence that it represents the cross-sectional opinions. So, however, in India and in Nigeria, because they are both very big countries, and the way that they're structured, a lot of the health decisions are state level. So in order to better inform decision makers within those two countries, we did decide to do 5 states within Nigeria and 4 states within India. So you'll see a higher target sample size in those countries. And then again, when we're like doing the analysis for this stuff, we need to take that into account. We have a lot of responses from Nigeria and we expect to have a lot from India. So we'll need to balance that out to make sure that they don't drown out the other voices in the results. So this is a little bit complicated, but basically it's a multi-stage sampling approach. So what we wanted to do was select areas randomly within the geographies. And within those areas, we randomly select subpoints. And then that's where we go to approach participants. The reason why we do it this way is we want to give everyone as much of a chance as possible as being asked to be participating in this study. Because we want to get as wide of a perspective as possible from the general populations in each of those areas, what they think. So we divided each section into 40 sections, and then a random number generator selected 14 of those sections. And then in those sections, we selected subsections. And we have 2 ways of doing this. We had passerby surveys and then house-to-house surveys, depending on a few things. In Kenya, it was a monsoon season, so you can't be standing in the streets. In the Philippines, they would not prefer to have people that they don't know in their house, so it's better to do it on the street. So this is why we've selected differently for those 2 different circumstances. Now for the healthcare worker survey, which is a separate survey, we assumed again the healthcare workers would 50% would accept it, but because this survey, because healthcare workers are pretty busy right now, so we can't just go into a hospital and be like, hey, spend 20 minutes telling us your thoughts. We did this online and through telephone. So we got rosters and lists of professional organizations and associations, and we went through those and distributed the survey via WhatsApp, via Telegraph, and then via phone calls. So when we do it this way, we know that we're not gonna have as high of a response rate as if we were going in person. So we did expect up to 50% non-response rate. So we targeted to reach around 800 healthcare workers in each of the countries to get the anticipated sample size. Okay, so now I am done with the methods section. So I don't know if there's any other questions before I jump into the results.
If anybody has any questions, don't hesitate to put it in the chat or raise your hand. And I'm sure if there is a future question related to methodology, once the results come out and you start thinking through it, again, don't hesitate to pose those.
All right, well then I will continue on. Great. So just to highlight again that these results are preliminary. And so just understand that we're still in the process of collecting all the results. We haven't collected all the results from all the countries, but what we do want to get this information out in a quick manner because we think it's valuable. So just bear in mind that these are preliminary and we have not done the statistics on it, right? So we haven't looked for the regressions to see if things are significant or not. What I'm be presenting to you today is descriptive. So this is just telling you what the data are saying, not looking at any of the deeper associations that may be there. So we got 4,371 respondents from Indonesia, Kenya, Nigeria, Peru, South Africa, and Philippines. And it's a fairly even split between males and females. The age range median for both males and females is 36. So It's fairly the same across all the countries. There are some countries that skew a little bit older and some that skew a little bit younger, but not too large of a deviation from this. The preliminary demographics show that the majority of participants, both male and female, have secondary or primary education. So we have very few numbers of master's, PhD, very few numbers that report having no education. And then the Islamic, just to highlight that this comes primarily from Nigeria, from some of the northern areas of Nigeria. In terms of demographics, what we see is that the most often reported category here for both male and females is self-employed full-time. And this could mean a lot of different things in different contexts. It could be taxi drivers, it could be small-scale farmers, and a lot of things in between. So to start with the perception of risk, so 36% of respondents felt themselves to be at a moderate to high risk of COVID-19. And we see here that no risk and low risk were 46%. In terms of previous experience with COVID testing, in terms of ever having COVID, 88% report never having COVID. 4% report having COVID confirmed by a test. 3% report having COVID confirmed by a healthcare worker. And 2% don't know, and 3% think so, but it was not confirmed by neither a test nor a healthcare worker. Of those who have tested for COVID-19, how many times did you feel you needed a test and could not access it? So it's 44.8% of those who have had a COVID test before report at least once they felt they needed a test, but they could not access it. I just want to highlight that this aligns with another set of work that we're doing in 10 countries, which looks at general perceptions of access to COVID testing. And this is it's a living data collection tool. But it's around 50% of the respondents in that work report at least once needing a COVID test and not being able to access it. So these two data points align fairly closely. In terms of willingness to use a SARS-CoV-2 self-test, if the tests were available in your country and you felt that you needed to test for COVID-19, how likely are you to use a COVID-19 self-test? So what we see here is that 80.5% of respondents are very likely or likely to say that they're willing to use a COVID-19 self-test. Here's just a way of looking at this by country. So we do see that it differs, right? So in Indonesia, you've got a lot less very likelies compared to South Africa, where you have a much higher number and percentage of very likelies being willing to use a COVID-19 self-test. Now, we need to look into this more, but just from looking at the kind of preliminary data, in Indonesia, I believe it was around 4 or 6% reported not being able to get a COVID self-test when they felt they needed one. Whereas in South Africa, it was over 40%. So there may be, and we'll look at this closely, some associations between willingness to use a self-test and perception of being able to access the current COVID-19 testing. This also just looks at this through education level. So what we see here is that people with higher education are more very likely to support using a COVID self-test than people with no education or other education. Concept of needing a test, it is abstract. So, but this is the nature of theoretical acceptability questions, right? On the survey, what you need to do is you need to ask all these questions within 20 minutes. So this is relating to the question in the chat. Could you please clarify the concept of needing a test in the absence of treatment for COVID? So perhaps you need a test because you feel like you've been exposed to somebody who has COVID-19. Perhaps you have symptoms. Perhaps you may be visiting a family member and you want to see if you know a family member who may be sick or at risk. Perhaps you may have family members at your home who are elderly or immunocompromised or children. And so you would like a test to understand if you may be having COVID, that you might infect them. So that's generally speaking. And we are looking deeper into this in the qualitative aspect. That's where we can kind of pull out a bit more perceptions around need for a test. But what we can say is that there are people who do feel that they need tests, even if they may not have a clear pathway to treatment because of many things: travel, not wanting to infect others, wanting to know if they should self-isolate, etc. So this is a very busy slide. And these are the reasons for being likely or very likely to use a SARS-CoV-2 self-test. And the top 5 are highlighted. The first is that it would allow me to know my results faster. It would allow me to request treatment before I get too ill. It will allow me to make the test in privacy. It will allow me to calm my anxiety and fears about the disease. And these two are closely tied. It will save me time from traveling to wait in a clinic and lab, and it will save me money for traveling to a clinic or lab for testing. Now, of those who were unlikely or very unlikely to use a SARS-CoV-2 self-test, these are the main responses. It's just better to use a professional test than a lab. It will increase my anxiety, fears about the disease. I will not be able to access or request treatment afterwards. So I think that this stems to the question in the chat and Brooke's earlier question about actionability if there's not treatment available. But we do see that, the percentages are maybe not as high as we would expect. And I would not trust the results. I don't know if it would be accurate or precise, and it will be expensive. So just to say, for the willingness to use, the unlikely and likely, we will look at these by country as well. There does appear to be differences or spreads across the countries. And this may have to do with the general perception of trust in the health system in that particular country. All right, I see some more. Yes, so Trudy, I think we can continue this discussion more in terms of the specific wording. You do have to remember that each of these were these are all pre-piloted and then translated into specific languages. And so the idea between want and need in certain contexts may be a little bit fuzzy. So I just think that we should consider that. And then Vivati says 80.5% willing to access a self-test. That's encouraging. Is there a breakdown or a testing update by Islamic populations in Nigeria and Indonesia? So that's a very interesting question. So we will be doing a breakdown by the different regions and rural and urban in each of those regions. And in Indonesia, we did actually 2 different rural areas. One is primarily Christian, and the other is primarily Muslim. Sorry. So then from Peter, we're all freely reporting the results. So I'm not sure exactly what you're meaning, but if you mean if all were freely answering the survey, yes, everyone had to provide informed consent. And not everybody wanted to participate in the survey. So we do have documented that, the ones who refused and why, to help kind of understand what the population of who participated in answering the survey. Although, Peter, you also may be asking about a question that I'm going to get to later, which is, would people be willing to report their results, which is here. So I'll talk a little bit more about this slide that I have open right now. So if you used a COVID-19 self-test and its results were positive, would you communicate or report your results to your local clinic and or the COVID hotline? So 90% say yes, but we need to caveat that here because it is not clear. We weren't able to differentiate if this would be a identified result reporting or an anonymous result reporting. And that probably has some pretty important implications. So we are looking at the qualitative aspects more to understand what may facilitate or hinder people to report results. For example, if you have to report your results and you are forced into quarantine for a week, and that impacts your livelihood, and there's no unemployment, that would maybe impact a lot on your decision to be willing to report the results. All right. If you used a COVID-19 self-test and its result were positive, would you self-isolate? So 92% report that yes, they would self-isolate. Now, if they used a self-test and the result was negative, would you report the result? In this context, only 44% say that yes, they would report it. And likewise, if you had symptoms compatible with COVID and or you knew that you had been exposed to a person with the disease and you used a self-test and the result was negative, would you stop self-isolating? And 51% say yes. And then this is just some willingness to pay data. The majority of people would like the test to be free. And then the median was around 50 cents up to $1.30 in South Africa. So just in the interest of, well, here, I'll pause here before we go to the healthcare workers.
Yeah, and maybe I'll just jump in there, so they'll take a bit of a break, and highlight some points that we discussed between the two of us when talking about the profile of the people participating. So yeah, I'll ask Sanel to clarify a bit and maybe go into some detail on this, but a few questions we had about potential factors in the kind of data you're getting on this would be the issue of urban populations, which relates to access to testing potentially. So what is characteristic of the population, and also related to how digitally connected they are, whether by phone or by computer, and some of the implications there with in turn being able to find out information about testing. So those who could be accessed for the survey might also be those who are a bit better at navigating their way to find services. And finally, that the population is youngish, at least on the median side, and that this may also have influences on ease of accessing the services and information about them. Also may influence the perception of risk that we highlighted. So just to take away from that, and maybe I'll ask if you have any comments on it. The point being that to some extent these might be if the difficulty, if you had 50% roughly, I have to go back to the data in terms of access, that might already be the numbers might be higher than 50% challenges in access in populations that aren't meeting that profile, that aren't in urban settings, that can easily navigate, that are that have other challenges. So that's kind of a general takeaway. I know we said it's preliminary, descriptive, but would it be fair to say that the description of the population is maybe a bit more capable of accessing tests than we might expect the median, or?
No, so I think what you bring up is a really important point. So of the work that we're doing, this other work that I briefly mentioned in the 10 countries, that is a very specific data collection platform that you do need to have access to a smartphone to be able to answer. So for this 50% number down here, yes, those people in that work tend to be younger and have access to a smartphone. The people reporting in this work where it's a complete random sample, right? So everyone within the catchment area had as much of a chance to be approached for the survey as anybody else. So the idea is that gives you a more representative population. So with this survey here, we'll be able to look closely at how each of the population profile compares to the demographics in the country, but just say the median. So this is not the mean. This is the median. This is like the the middle number. We just use median here instead of mean because we don't know if the data are normally distributed, and you should only use mean if it's normally distributed. It's not technically, well, it's technically important, but for this conversation it doesn't. And just to say, these are just where most of the data lie, right? So where most of the people are between these ages, 28 and 46. But we had as young as 18 and we had as old as 98.
Okay.
And I do agree with you that perception of risk is going to be really important based on age and a couple of other things I didn't show here. But we will be doing that analysis, right? If people in different age bracket groups perceive that it's more or less difficult to get a test. And then we did look at urban in each of these areas. So I didn't show the breakdown here, but in each of these countries, we specifically are looking at rural and urban areas, with the exception of Brazil, because it's like the rural is like the Amazon, and India, just due to some constraints about timing. But I agree with you, Chase, that having the representative from both of those sections is going to be really important.
Brooke?
So I have a couple questions, and maybe it just, these are things that will be studied in the future more closely. One of which is whether we were able to gather any information on a little bit more, going back to what are the motivators for testing, but one question would be, well, do people know the symptoms of COVID, right? Because particularly if self-testing is going to be recommended for people at earliest symptoms, then of course, understanding whether people have knowledge of the symptoms would be relatively important. Related to the question of, that was raised about contact tracing or outbreak, contact exposure or kind of outbreak situations. In other words, to have a little bit more understanding of what might be the particular circumstances where a person would be called upon or encouraged to self-test, and their understanding of that and motivation to respond to those particular scenarios. I mean, I think if we didn't get that from this round of interviews, then we might look for it in the future. And then I guess related, and I know we probably are already thinking way ahead to test and treat in ways that overemphasize its importance, but somehow there was that question about that people were motivated if they could quickly connect to care and prevent disease progression, which is exactly the motivator that we're mainly thinking about. Mm-hmm. But to some extent, for a person to have responded to that question positively, they'd have to know that early treatment was important and the connection to care immediately was important. And you asked the question of people whether they would report positive results, but you didn't ask the question, would you quickly connect to care to get treatment if treatment were available? And so again, that I think would be a highly important question to ask. If we didn't get it this time, then to get it the next time.
Absolutely. I think that that is critical. And I think it highlights the need to think already about the supportive packages that should and could be offered along with the self-testing, right? Because it's not just the supportive package of this is how you do the test, this is how you interpret the result. It's also, okay, so what do you do next? What are the treatments available for you? What are the linkages? So yes, I agree that those are really important information to understand. And the qualitative work we do hope will elicit some of this. Those questions were not explicitly covered in the survey, but I think what is really going to be critical for us as a global community is to have a better understanding kind of the knowledge, attitudes, practices, right? So what you were saying, what do people really know about COVID in a systematic way? What are the motivators for testing? What are some of the barriers? It's all critical stuff that I hope that people are going to be able to pull together.
So just to pass to Peter, and then after Peter, we'll let Sonia finish the second part, because I want to be conscious of time, and also I think this other element of the differences, potential differences between healthcare perspective and patient population perspective is relevant to emphasize. And Talo, I'll make sure to come back to you right after Peter's, or after Soniel makes her intervention. So let me pass to Peter.
Yeah, thank you very much. I just wanted to ask, maybe I've missed it, if there was some kind of investigation into the relationship between those people who took the survey, those people who are willing to take the tests, the rapid tests, and those people who are not willing. Are they the same people who had a bad perception about vaccinations, if there was a correlation? Because it measures perception and attitude. Was there such a relationship?
Yeah, well, that's an excellent question, Peter. And we were focused on the testing aspect, and so we were not able to go into questions about vaccination, right? But I think that we will be looking at associations between perception of risk, previously having COVID, perceptions others in the household at risk. That's what we will be looking at, but we are not able to look at perceptions of testing versus perceptions of vaccination. But I do agree that that's a very interesting thing that should be explored.
Just add, I think also the linkage to perception of risk and some of the attitudes towards reporting and self-testing. Tala, can you, yeah, why don't you make your intervention now? Thanks.
Thanks. I'll be brief. I just wonder, because I work a lot on knowledge incubation and perceptions and risk, mitigating risk. I wonder if we can't also look at the alignment of public health programs or the misalignment of public health programs in countries, and how that's very confusing to digest for communities where you have piecemeal data surveys and people asking for different things and not aligning in terms of their programs. I wonder if you're considering looking at that in terms of messaging. I know we saw that with Ebola, and that there was an effort made by finally the local communities to create these pop-up tents, these knowledge incubators that were transparent to provide the information so that it was more community-led, but more specifically clear in terms of the alignment of programs.
Yeah, I think that that's a critical point, but that's like a pretty big point, right? So that's not just talking about COVID-19 self-testing. I mean, that's alignments across multiple areas. I suppose providing information on the whole COVID, I guess, life cycle as it would be, which I would see as being incredibly important. And I think maybe that's one of the intentions. I feel like, isn't that what ACTA is supposed to be doing? I don't know. I mean, I'm only involved in this one little piece, so.
Yeah, and but Tala, it'd be great to follow up maybe after the call offline about some of that, some of the work or material describing that work and learning a bit more about it. Because yeah, definitely going forward, I think it'd be interesting to understand how the Ebola experience informs, well, at least from the civil society side, the contributions and perspective that we're adding. So definitely would love to chat more about that. And let's just pass to Soniel to complete this second part of the results.
All right, I'll try and be super quick. So unsurprisingly, the nutshell is that healthcare workers do not think that people would do the right thing as much as people think that they would do the right thing. So that's the very high level takeaway. We have surveyed 1,706 healthcare workers so far. The majority are female, split between a wide variety of different types: community health workers, all the way up to others, which is just a catch-all for radiologists, health management, record people, those type of things. So now here, which is interesting, is 24.8% of healthcare workers reported that those whom they attend to at work are never or rarely able to access COVID-19 test if they need it. So this is a bit of a different perception than people. who, of those 44% said that they were not able to access a COVID test at least once when they needed it. So in general, do you agree with the concept of people being able to self-test at home for any of their own diseases? And 60% of healthcare workers say yes to this in general. However, when you ask, do you agree with the concept of people being able to self-test at home on their own for COVID-19, it moves up to 68%. And then if we ask, if COVID-19 self-tests were available in this country, how likely are you to support that the general population uses them? And 75.6% of healthcare workers report being likely or very likely to support that the general population uses COVID-19 self-tests. So then the willingness to use COVID-19 self-test, what would increase your willingness to use it? They think it would be more convenient for the population, it would help promote early diagnosis, and it would help the healthcare system to decongest the clinics, labs, hospitals. What would decrease your likelihood? So now in this case, the healthcare workers were asked both of these options. So healthcare workers thought that it would discourage positive cases to report the results. It could lead to false negatives, and it could lead to infected people testing incorrectly, and as a result, spreading COVID-19. So should it be a requirement for people buying or accessing a COVID-19 self-test to report the result to the healthcare system? 65% of healthcare workers said yes. And now this is what's interesting is if people used a COVID-19 self-test and had a positive result, would people communicate the result to the clinic or the COVID hotline? Ooh. Now here, 43% of healthcare workers thought that most people would, so only 6% thought that everyone would, and 34% thought that only a few people would. So we're splitting, it's about half that most, or sorry, more than half, can't do math anymore. So we're looking at a lower level of thinking that people would report the results among healthcare workers than recipients of care or general population themselves. And then I won't go over this just to leave some time for more questions, but just to say that we're also doing this qualitative interview portion. And in each country, we will be doing semi-structured and group interviews with community representatives, healthcare workers, and potential COVID-19 self-testing implementers. So that work is mostly complete, but unlike the surveys, it just takes a lot more time to go through and analyze and code the qualitative data. So we do hope that those analyses will be complete, and we are already starting to disseminate the work. So yeah, so thank you for listening, and keen for any other questions or comments.
Okay, great. With that, let's open the floor. So I see FIFA has her hand up, and then Brooke.
Thanks so much, Sanjal, for sharing that, and obviously FIND produces a lot of useful research in the COVID pandemic, such as the review on sensitivity and specificity of these antigen RDTs back in the day. But, one thing we've been worried about is the WHO just not taking FIND's evidence into consideration, into, speeding up or accelerating their own guidelines. We're just sort of wondering what your strategy is for engaging the WHO on this. And I appreciate if you can't answer an open floor. But, we're really keen to see this translate into some kind of acceleration into their guidelines. They keep saying it's going to take another 4 to 6 months to develop their self-testing guidelines. So just wondering what your plans are on that. Thanks.
I think that that's an excellent question. And I think Elena was here, but I think that she has stepped out. So the reason why I would defer to my colleague Elena is because she's leading a lot more of this. I'm just doing this one part. So she, I think, has a better picture. But what I can say that is heartening is there have been coordination meetings where WHO has been actively pulling people together and saying, okay, what information is out there? What are our plans? I think some of the people who, I think we now have a chance to move as quick as possible for WHO. And that's one of the reasons why I'm keen to get this information out to share and show and sensitize to people. So then WHO, and we sensitize this to WHO as well, so they can see some of the data that are already out there. But I think that, they'll have to do their grade process, which is the systematic review and all those things. So as far as what time that takes, I unfortunately don't have any visibility.
Brooke?
So maybe this is relates to the qualitative next steps, and you say there seems to be some flexibility in the qualitative work to go a little bit beyond the scope of the questions asked. But it was pretty obvious in the very quick look at the health worker responses that they weren't really thinking of there being treatment available as well, as affecting people's motivation and affecting, in fact, the health workers' attitude towards self-testing and connection to care either. So I'm wondering whether your qualitative questions are already pre-approved, or whether you have some greater flexibility to try to maybe expand things a bit, or if necessary, even to think about expanding the protocol. Because when your survey was designed, it was kind of pre the promising readouts on antivirals, et cetera. And I think probably even before the ACT Accelerator was finally convinced to join the diagnostic and treatment pillars together, and to really start talking more proactively about a test and treat strategy. So I'm just, I guess, is a hopeful question that you can begin to focus a little bit more on that and the qualitative steps of your research.
That's clearly an important step in where the future is going. So just to clarify that, unfortunately, the qualitative work has been the interviewing has been completed, but I'm not able to show those results because you have to code and analyze. It's a lot longer process than crunching some numbers from a survey. But what I think you do bring up is the very important aspect of understanding this. And as you talked about how, I guess now the testing and treatment pillars are going to talk to each other more. I think to do this well, we need to work with the people with whom the treatment is within their scope, right? And so hopefully we'll be able, we're glad to partner with others or do additional work, if it's fitting, to understand those questions.
So yeah, and then Brooke, just to add to your point about the impact of test and treat, I think it's really interesting because if test and treat does come out, then attitudes towards testing certainly will be expected to change. But I also think a factor in that might be what process is being adopted at national level to access treatment. So, we could conceivably see a case where maybe self-testing and positive reports or positive test results are not being accepted at face value for accessing treatment. Maybe some rules would be imposed at a country level to control limited supply. I don't know, but it's just interesting to think through that there could be various factors shaping access to testing demand in the event of test and treat arrival or accessibility of oral antivirals, and whatever approaches are adopted to access those antivirals in country. But I'm conscious of everybody's time, and we're coming to the end of the hour. Just to note that we will have the recording, we'll have the link to the recording, and our plan is to share that. And also, I wanted to note something more broadly that has come up in these values and preferences surveys is that I think it's important for civil society to push for these values and preferences surveys to be taken more seriously, not just as a complement to a dossier for WHO guideline approval. It's kind of a general description, but just speaking for myself, sometimes we get the sense that it's included to complete the dossier because that's part of the steps that need to be done. But often on the back end, and not enough at the front end, and not enough weighted with other elements of dossiers for evaluating guidelines. And that's just not about self-testing. That could be any elements of service delivery. So this values and preferences work. Right, the quality of it depends on the methodology, depends on the resources that are allocated to it. But as something, especially for civil society, especially for communities, it's a really important tool to get right. But also, there's some advocacy for us to do to make sure that it's getting there early enough, and also is effective in pushing forward perspectives in the success of these public health interventions. All too often, the guidelines are kind of, let's say, weighting the medicalized, the medical perspective on a lot of interventions, and this gets secondary treatment. So I'm glad that Tanya was able to present this for the context specifically of COVID self-testing, but I think it also is relevant to take that perspective on the this tool and where it fits in some of our larger work related to assuring that what the community wants and what's most accessible for them is taken seriously. And with that, I'll stop because we're at the top of the hour. Just wanted to thank Sanyel and the colleagues from FIND for being available. We hope, hasn't been confirmed, but we hope to do something like this more regularly, maybe as often as once a month, on various topics that we think are relevant to share and consult and get feedback on from civil society colleagues. And as I mentioned, now that we have some more capacity with regards to supporting the civil society delegation, because everybody that's been a representative has been a volunteer and is doing that out of their own time, and we all know the time's limited. We hope to be able to structure more regular exchanges, not just with FIND, but to share what's going on with the with what civil society is doing in ACTA as representatives, but also we plan shortly to reach out to organize calls about the new strategy, to share what's happening at the whole strategy level, what specifically is involved for the proposed strategy for the diagnostics pillar. And then we're also hoping to schedule a broader call about test and treat, and where that fits within the current strategy, and feedback on, or just to share the information and get your feedback and thoughts, so that we can take that to the ACTA leads when we're engaged with them on the calls. And don't hesitate to reach out to myself or Carolyn or FIFA, or Peter. I see Zahed's on the call as well. Those are all also reps. And yeah, a special hello to Francisco. Nice to see you on the call. So, all right, that's it for today. And thanks again for joining. And yeah, hope everybody has a nice week.
Thanks so much, everyone. Sonia, really great study. Thank you. And thanks, Chase, for organizing.
Thank you, everyone, for your time and for the attention.
Thanks, everyone.